So, good evening, ladies and gentlemen, dear colleagues and friends around the world. I'm very happy to welcome you to the last webinar of this year on prostate cancer and entirely focused on side effects and CVD, cardiovascular side effects mainly, and ongoing trials in that respect and how to reduce side effects related to prostate cancer treatment. I'm very happy to announce that we have three distinguished experts in this field. First of all, we have a leading cardio-oncologist from St. Louis in the United States, Daniel Linehan, who is the immediate past president of the International Cardio-Oncology Society, and he's been a leading cardio-oncologist for more than 20 years. Then we have also one of our leading medical oncologists, and now from the United States, from Boston, and Mark Gornick, who is one of the pioneers in terms of ADT, hormonal therapy of prostate cancer. He was the first one to launch Avaraderone, to launch hormonal therapy with an antagonist in the US. Avaraderone many years ago. Mark Gornick is a medical oncologist and very well known in the oncological and urological community worldwide. And finally, we have Neil Flechner, who is a practicing urologist professor in Toronto, University of Toronto in Canada. He's also been one of our leading clinicians and urologists around the world in terms of uro-oncology and especially prostate cancer. So we have a fantastic team to give you some very interesting data in terms of cardiovascular side effects and other side effects related to prostate cancer treatment 2021, and what we've learned over the years and what we need to pay attention to in the future to really reduce the risk of CVD especially. So I would like Mark Gornick, our oncologist from Toronto, from the well-known university in Boston, to start up with his presentation. It has been pre-recorded, and there are some questions, remarks allowed in the end of this presentation. So whenever you have a question you want to raise to Professor Gornick and other speakers later on, please use our technical facilities to do that. So I'm happy to introduce once again Mark Gornick to give his presentation reflecting the history of ADT and risks associated with hormonal therapy in prostate cancer. Thank you.
Thank you very much, Dr. Abrahamson. Thank you very much for that kind introduction. I'm going to speak about hormonal therapy for prostate cancer with cardiovascular considerations, giving a historical and current view. Those are my disclosures, none of which are relevant to this discussion. Historically and currently, maintaining cardiovascular health and minimizing cardiovascular morbidity and mortality has got to be a priority of every physician in the management of patients with prostate cancer. This has been historically shown by the VA studies done in the United States, showing that estrogens decreased the cancer death rate, but it was offset by increased cardiovascular deaths versus orchiectomy. So here we have a decrease in the cancer deaths when patients were treated with estrogens or orchiectomy, yet the cardiovascular deaths when patients were treated with estrogens or orchiectomy was substantially greater, offsetting the benefit of the treatment. Likewise, if we take a look at later studies that compared estromustine phosphate, a combined moiety of estrogen and hormonal therapy and cytotoxic chemotherapy with diethylstilbestrol, an unacceptable lethal cardiovascular mortality of 7 to 16% resulted in these studies done in the 1980s. So cardiovascular morbidity has always been front and center in the management of patients with prostate cancer. Then the LHRH agonists and GnRH antagonists come along. In the pivotal study of Lupron versus diethylstilbestrol, there was less cardiovascular morbidity, thrombosis, and myocardial infarctions in the Lupron arm compared to the DES arm, and that, in effect, led to the approval of daily subcutaneous Lupron as an alternative management to either orchiectomy or estrogen in the overall management of patients with advanced prostate cancer. Along come the GnRH antagonists, initially Abrelix, Degarelix, and now Relugolix. Possibly less cardiovascular toxicity, but it's really been unconfirmed. Mechanistically, could that be due to changes in follicle stimulating hormone between agonists and antagonists, and the differential effects of plaque and plaque rupture between antagonists and agonists? This was put to the test in a comparative pronounce study of Degarelix versus Lupron. The study did not meet its accrual target. It was stopped prematurely. There was non-inferiority of antagonist compared to agonist in terms of cardiovascular morbidity and mortality, but there were more events, cardiovascular events, in the antagonist arm that did not reach statistical significance. So as of 2021, there are no conclusive data to yet support differing comparative cardiovascular safety profiles among agonists versus antagonists. What do these therapies do to cardiovascular risk parameters? This is a study that we performed looking at the comparative differences in cholesterol, HDL cholesterol, and hemoglobin A1C when patients were treated with either monotherapy Lupron, Lupron plus bicalutamide, or Abrelix. And the take-home point from these slides are that after essentially 6 months of treatment, Lupron and Abrelix, but not Lupron and bicalutamide, significantly increased total cholesterol, triglycerides, and HDL cholesterol, and all forms increased hemoglobin A1C during the first 3 months of treatment that turned out to be resolved by 6 months of therapy. There were no significant changes in fasting glucose measurements. So at least acutely, these agents can have profound effects on many of the risk factors that we associate with developing cardiovascular morbidity and mortality. If one takes a look at large populations, this is from the VA and Medicare databases. If patients were treated with a GnRH analog, the likely increased incidence of diabetes, coronary disease, MI, sudden cardiovascular death, or CVAs was 1.2 to 1.4 times greater than those on ADT, and very, very similar data in a Medicare database, very, very large databases with many tens of thousands of patients. So the question is, can we identify patients who are at most highest risk of developing excess mortality from hormonal therapy when they've developed a form of prostate cancer that requires systemic therapy with ADT? Can we stratify the risk of cardiovascular morbidity and mortality by baseline characteristics? This is a study done by Anthony D'Amico looking at a reanalysis of patients' cardiovascular morbidity using the so-called ACE-27 score, which is the Adult Comorbidity Evaluation Score that looks at a wide spectrum of parameters in which patients can be identified as having either no or mild cardiovascular morbidity versus those with severe or moderate cardiovascular morbidity. And this was basically reanalyzed by hormonal therapy versus no hormonal therapy according to each comorbidity group. And what was shown that if you ended up, these are patients that required ADT for their prostate cancer, and those with no or minimal comorbidity again showed the advantage of ADT or AST, androgen suppression therapy, with no or minimal comorbidity when added to radiation therapy. However, in those with moderate or severe comorbidity, that improvement with ADT seems to be lost. And basically, they may have been harmed by hormonal therapy. So clearly, pre-existing cardiovascular parameters prior to the administration of ADT can be an important determinant of what's likely to place the patient at increased risk during the subsequent administration of ADT. Likewise, a very large study done by Nander et al. Looked at over 5,000 men who got radiation therapy and with or without hormonal therapy. These were mainly low to intermediate risk patients. The endpoint was all-cause mortality with a median duration of 5 years. And the hormonal duration therapy was 4 months in the study. And we can see in those patients with no comorbidity, there was very, very little difference in all-cause mortality, independent of whether they were getting neoadjuvant hormonal therapy or not. And those with one cardiovascular risk factor identified as hypertension, hypercholesterolemia, or diabetes, again, no significant difference. However, when we look at those patients that had a known coronary artery disease that during hormonal therapy that resulted in either heart failure or myocardial infarction, there was a substantial increase in all-cause mortality in those patients receiving neoadjuvant hormonal therapy. So these are folks with pre-existing coronary disease. Again, very similar to the previous data, that if your patient has a pre-existing cardiovascular issue, they are at much higher risk of developing issues from the administration of ADT. And likewise, this is shown here in tabular form, those that had a history of MI or CAD related congestive heart failure, number of deaths there was substantially greater in those with either no comorbidity or those with a single coronary risk factor. So their conclusion is no myocardial infarcts, CHF, or cardiovascular comorbidity. ADT did not increase the 5-year all-cause mortality in the setting when patients did not have prior history of coronary disease. So in summary, randomized trials have established that hormonal therapy improves the overall survival for patients with intermediate risk through node-positive prostate cancer. It induces physiological changes and appears to be associated with excess mortality in the 5% of men with CAD-induced CHF or myocardial infarction. The small proportion of susceptible men may partially explain the lack of detection of excess cardiovascular mortality in some trials. So again, this emphasizes the necessity for a cardio-oncology consultation in those patients that may have pre-existing or unsuspected coronary disease prior to the administration of hormonal therapy. Just a few final comments on practical problems in modern day practice. Urologists are increasingly administering ADT, often orally administered agents, after LH or GnRH analogs in metastatic castration-resistant prostate cancer or non-metastatic castration-resistant prostate cancer. And these include abiraterone plus a steroid, usually prednisone or prednisolone. They could include enzalutamide, radium-223, PARP inhibitors as well. So urology offices, at least in the United States, may not be optimally set up for monitoring cardiovascular risk profiles or having the wherewithal to do the laboratory testing to assess changes in values during the administration of ADT. And understanding metabolic consequences are crucial. I'm going to use abiraterone as an example. So abiraterone, which is commonly used both in castration-sensitive and castration-resistant disease, is an inhibitor of 17-alpha hydroxylase and 17-20 lyase. Now, you remember from your early biochemistry days that the 17-hydroxylase pathway leads to the development of glucocorticoids. The 17-20 lyase pathway leads to the development and the manufacture of sex steroids. But as you know, the mineralocorticoid pathway is not inhibited by abiraterone since it does not affect the desmolase pathway. So what happens is when patients are given abiraterone, they have low cortisol, low testosterone, but ACTH overdrive drives the mineralocorticoid pathway to produce excessive amounts of mineralocorticoids, with the main one being aldosterone. And what do we know about excessive mineralocorticoid administration? Well, first of all, we try to minimize that by giving concomitant prednisone or prednisolone, usually in a dose of 5 milligrams of prednisone. But despite that, the consequences of mineralocorticoid excess are fluid retention. So if urologists are caring for patients with Avaraderone, this will add weight to the weight gain of ADT. My question is, are you weighing your patients in your practice? The development of hypertension, especially in patients with pre-existing hypertension, this can be sometimes severe, requiring a change in blood pressure medicines. Are urologists routinely checking blood pressure in those patients that they're caring for undergoing therapy with Avaraderone? And most importantly is hypokalemia. This can be severe and proarrhythmic. Are urologists routinely checking electrolytes and potassium levels in patients that are on Avaraderone? And this is important because the urologists that are administering these agents may be seeing patients more frequently than the patient's own primary care physician. So these three components are essential to incorporate into clinical practice for maintaining the safety of pre-existing cardiovascular issues. And why is potassium so important? Well, as you remember again, the QT interval is affected by potassium. Things that increase the QT interval in the electrocardiogram lead to delayed repolarization. And the risk factors for increase in the QT include age, gender, decreased serum potassium, as well as decreased serum magnesium, underlying heart disease. And what happens with a prolongation of the QT interval is one gets a delayed repolarization, leading to an increased QT duration and the likelihood and potential for developing ventricular fibrillation or torsade de pointe. And you must recognize that ADT, whether it be LHRH or GnRH, both increase QTCs to begin with by 12 to 18 milliseconds. So oftentimes we'd have patients that had sudden death shortly after administering hormonal therapy that we thought was just due to their cardiovascular issues. This may have had some effect on elongation of the QTC interval in patients undergoing ADT, and especially those undergoing therapies that may decrease potassium. Based upon all of this, the FDA in the United States came up with a drug safety communication of ongoing safety review of GnRH agonists and possible increased risk of diabetes and certain cardiovascular diseases. And I'll end my presentation with this time with the FDA recommendations that healthcare professionals should be aware of these potential safety issues and carefully weigh the benefits and risks of GnRH agonists when determining treatment. Patients receiving GnRH agonists should be monitored for the development of diabetes and cardiovascular disease. Healthcare professionals should manage cardiovascular risk factors for patients, such as smoking, increases in blood pressure, cholesterol, blood sugar, weight, according to current clinical practice. They should not stop their treatment with GnRH agonists unless told to do so by their healthcare professional. So again, this is a very, very important, significant issue that needs increasing education and the incorporation of other disciplines to help manage patients who are undergoing ADT as it relates to cardiovascular morbidity and mortality. So I thank you very, very much for your attention to this, and I'm very happy to answer any questions. 51% initially thought the answer should be potassium and blood pressure, which is the right answer, and that would increase to 83%. So that shows a major improvement in learning. And can we show the last question before I turn the program back to Dr. Pranders? If you answered question 1 correctly, how many in your practice are actually ordering these studies on a regular basis? 100% of the time? Only if the patient has a cardiac history? Less than 50%? Or I did not know that I had to order these studies? Or 0%? I know about the studies, but never ordered them. So be truthful.
we should have the outcome.
And the answer?
Yeah.
So a quarter are measuring them all the time. About a third are measuring them only if the patient has a cardiac history, and substantial areas for improvement. So that's great. So I hope this lecture will have some alterations in some of your ordering components of your practice. So thank you very much, Dr. Abrahamson.
Oh, thank you very much, Mark. It was a splendid presentation. So I think I got the take-home message based on the answers. There is one question coming from the rest of the world here outside the US. He says, he asks for CV risk, hormonal therapy is also including orchiectomy, or are we only talking about injections? Are there any difference between orchiectomy versus agonist and antagonist?
I'm not sure if that's actually been appropriately studied. I'd be very interested in the comments of my colleagues. But don't forget that if FSH is important in aspects relating to cardiovascular history, then there's a major difference between FSH levels between agonists, antagonists, and bilateral orchiectomy. I'm not sure it's ever been studied appropriately because it's always been confounded by potentially concomitant administration of estrogens.
That's correct.
All the cardiovascular data really exists for pharmaceuticals.
I don't think we have a clear answer to that question, actually. But of course, there are minor studies, but I don't think we have a final answer to that question. But you're criticized mainly indirectly, Mark, and we have discussed that over and over again, whether or not urologists, they don't really pay attention to blood sugar, cholesterol, weight, and so forth. But I think some of us, we do, and we check that on a regular basis down the pathway when we put any patient on agonist or antagonist treatment. I think that's crucial, and you're totally right that there are unfortunately too many colleagues out there, especially in your local community, that don't pay enough attention to the FDA recommendation and so forth. But I guess, Mark, to be correct, there are even some medical oncologists not paying too much.
No question, and primary care physicians. And I think there were data just recently suggesting that urologists are increasingly prescribing and maintaining patients, even in the metastatic castration-resistant population, especially with orally administered agents such as enzalutamide or abiraterone, and even those with genomic abnormalities leading to the use of a PARP inhibitor. And so these are I think it's a little bit incorrect to think that even though it's orally active agent, it doesn't necessarily require more close monitoring than some of the other orally active agents that non-oncologists and non-internists provide. So I think it's a very, very important component. And in order to maximize the safety of our patient population, I've tried to provide some very practical points.
Thank you very much. I don't know whether we have time for any more questions. I think we have some questions we can answer them in the end of the three presentations. So thank you once again, Mark Garnick, for your excellent presentation. So we have to move on, and the next speaker is, of course, our Neil Flechner, our urologist from Toronto. Are you ready to give your talk?
Yes. Let me just share my screen. Can you see my screen?
Yes, we can indeed.
Okay, wonderful. So good day, everybody. I'm just gonna get going back to the beginning. Good day to everybody. I know people are in different times of the day, and it's my pleasure, and I want to just again thank the group for inviting me to speak today about cardiac disease and androgen deprivation. And here are my disclosures. There aren't many relevant ones for this particular talk. From the outline point of view, I just want to quickly review pivotal data. I know our next speaker is going to as well, looking at associations with ADT and cardiac disease, and also review a novel tool. I think the discussion just earlier about how urologists are working in the clinic, both in terms of managing preventatively for cardiac outcome for our patients on ADT, as well as the novel angiogen axis inhibitors is important, and also in identifying this concept of pre-existing disease. And I think we've all learned over the last 15 years, really the long-term complications of ADT, which we never really had to learn in the old days when patients would live 2 to 3 years. They were all identified with advanced prostate cancer and would die in 2-3 years. And we didn't really understand or need to appreciate the long-term complications. And of course, the bottom right is what we're focusing on here is the cardiac outcomes. But of course, when we think about that, a lot of it's related to the metabolic changes and the diabetes changes that are induced by these drugs. So weighing in on ADT and cardiovascular risk, I think a variety of societies and the sort of emanation, if you will, of cardio-oncology, I think has started to really make a difference for us. And I think this particular publication is just a snapshot from the Canadian journal, but really showing that the cardiology community is starting to become aware of this. And you can see here at the bottom that cardiotoxicity is now recognized as a leading cause of survivorship issues for patients with advanced cancer. And again, this gets to this concept of a multi-hit hypothesis that patients have, baseline risk factors and cardiac disease. And then when you add in additional therapies, we end up a decreased cardiac reserve, which ultimately manifests as cardiac morbidity and mortality. And certainly these societies are now recommending the evaluation of cardiac risk factors for patients undergoing cancer therapy. And I think sometimes as clinicians, we don't recognize that LHRH therapies are sort of included in that basket. And I think we've always been taught to think about drugs like adriamycin and traditional chemotherapy only. And it's also important to recognize that metabolic syndrome is not only a risk factor for heart disease, it's also a risk factor for prostate cancer itself. And you get a scenario where in this particular study, Swedish men had basically that with prostate cancer had a higher risk of cardiovascular disease. That men with prostate cancer had a higher risk of cardiovascular disease than men average men in the Swedish population. These were men on surveillance. So again, it's suggesting that there's a higher prevalence of pre-existing cardiac disease. And it's interesting, if you look at the published literature, this was one of meta-analysis that looked at the risk of cardiovascular disease and ADT. You can see that the observational studies tend to be largely positive, the randomized trials perhaps less so. And there's a variety of reasons why this may be. This is a paper from Zalewski's group. It's showing that older and less healthy men are likely to be included in observational trials. So it's not surprising that randomized data may not be as consistent with observational data, but that doesn't make the observation and the association untrue. And again, Dr. Garnick touched on this concept of the significance of pre-existing disease, and we're all very aware of the fact that in most well-done study, about a third of prostate cancers have pre-existing disease. And as was shown earlier, it seems to be those men that are particularly at risk for ADT-induced trouble. And this was one of the trials published in 2015, looking at neoadjuvant treated patients. And if you look at those without cardiac comorbidity, here on the left, there's no difference in cardiac events as opposed to those with prior MI and cardiovascular disease. And this was shown earlier. I'm not going to overemphasize it, but this concept that if you treat patients with moderate or severe comorbidity, you could actually flip the survival curve potentially towards a negative one, meaning harm associated with these agents. And I often use this example with my patients, particularly those who have a significant comorbidity, that the timing of ADT and the choice of starting ADT is very much very important to take this into consideration, because we don't want to bring their date of death up forward due to adverse effects of the drugs themselves. And again, further a concern due to novel agents which further inhibit the androgen axis. And this is some data showing, again, even increased cardiac concerns using abiraterone and enzalutamide. I think many of us are familiar with these data from the CS group of trials from Ferring, where they looked at a smattering of studies done, some short trials, some longer trials, some degarelix or an antagonist against Lupron or an antagonist against Zoladex. And again, this leads to this concept that are antagonists any different than agonists in this context of CV disease? And a pooled database was created. And you can see here, if you look at the incidence of CV events, maybe they're a bit lower in the degarelix arm. But when you look at those with pre-existing versus non-pre-existing condition, it's interesting to look at it. These are the overall curves, but when you look at those without men without baseline CV disease, there's no difference. But look how the curves tend to spread in those with pre-existing disease. And I think this is not only a statistically significant, but clinically significant difference, perhaps suggesting, and I think this gave weight to this possibility that antagonists have a difference in agonists. Additional observational data have recently been published. The data by David Margell is actually one of my fellows in the Journal of Urology, where he took patients with significant pre-existing disease and recognized a very high incidence of cardiovascular morbidity in those with pre-existing disease treated with an agonist versus an antagonist. And indeed, meta-analyses have confirmed this association. But what about the randomized data? So there have been two recent important papers, the Relugolix trial, the HERO trial, which is an oral antagonist. If you look at the incidence of major cardiac events between Relugolix and Luprolide, there was not a difference, about 1.3% in both, but there was a higher incidence of what they called any grade MACE, or major adverse cardiac event, using that. So perhaps the suggestion that the less severe grades of cardiac events are more prevalent in those treated with an agonist versus an antagonist. And then Pronounce came down the pike just a few weeks ago, and this was, of course, a randomized trial comparing degarelix to Luprolide, specifically with a cardiac outcome. These were patients with pre-existing cardiac disease. And as was just alluded to by Dr. Garnick, there was not a lower incidence of time to first adjudicated major cardiac event in terms of the antagonist. In fact, if anything, the hazard ratio was in the opposite direction with a 28% increased risk. And I think what's key about this study is patients were under the care of a cardiologist. They were all getting active secondary and tertiary prevention, statins, hypertension management, perhaps aspirin. And these interventions, as we know, may have a very significant impact, particularly in this trial. So the rates of MACE in general were lower than expected. They did have trouble with accrual, and they did conclude that the agonist versus antagonist issue remains unsolved. We just had accepted to prostate cancer and prostatic disease a futility analysis we did based on the Pronounce data, and we determined that really this trial was doomed to fail, and that a new trial would require almost 3,000 patients as opposed to the 900 that were planned in that trial to perhaps answer this question, at least in the setting when patients are being managed by cardiologists. What about the patients? What is their assumption, and what is their knowledge level in terms of this association? This was an interesting study done where 411 patients on LHRH agents were actually asked about what they knew about side effects associated with the drugs that they were on. And you can see here that only 8% were aware of the increased cardiovascular risk associated with prostate cancer ADT treatment. And not surprisingly, once they were made aware of this, this was not a significant concern compared to the other side effects. So perhaps we're not doing a good enough job with our patients and talking to them about this particular outcome. We're always focused on the hot flushes and the bone loss and some of the sexual changes, but perhaps not enough on this. So I guess the question is, as we just heard, how well are urologists managing the cardiac piece? I can tell you in my particular practice, I answered 100% to Dr. Garnick's questions. And the reason for that is every patient on ADT, and particularly those on the androgen receptor targeting agents, all get a blood pressure and a potassium at every visit. But nonetheless, there is a sense from urologists that there was a feedback that they do want to do a better job, and they do want to know, number one, understand the changes associated with ADT and the metabolic changes, but they also want to have a tool to perhaps be able to screen their patients quickly. But of course, urologists are busy people. The feedback we got in this particular Canadian study was that there was no standard approach. We're all too busy in the clinic. The Framingham system is perhaps too broad or too complicated. I'm not a cardiologist, and not all urologists have the adjunct of staff to have allied health professionals perform this task for them. So this is a paper we published in the Canadian Journal not long ago, and really this concept for recommendations was for each patient to really do a basic medical history. I think, you know, we're all doctors and we all did well in calculus, and certainly we can do a proper medical history, and then introduce this concept of the STAMP questionnaire. I'll get into that in the next slide, but a very quick screening set of questions to identify pre-existing disease, and then identify those who need to be seen in the cardio-oncology sphere. And so let me show you what the recommendations were. One, history, physical, basic metabolic, lipid profile, and of course the family doctor can do this as well. And then ask this very simple STAMP question. STAMP is a tool. It's 5 questions. You ask a patient, do you have a history of stroke, TIA, aortic disease, including aneurysm, prior MI or stent, and P is for peripheral artery disease. So S for stroke, T for TIA, A for aortic aneurysm, M for MI, and P for peripheral artery disease. And if you can ask those 5 questions, as I've done the last 35 seconds, then that's a reasonable screen for patients. And if STAMP is positive, as a urologist, you could consider secondary therapies, including, statins and maybe an ARB therapy or an antiplatelet therapy. And certainly I prescribe a lot of these in my metabolic clinic. But otherwise, you could obviously consider perhaps referring the patient on either back to the family doctor or to a cardio-oncologist. Who should we see that? We should say this patient for sure needs to go to a cardio-oncologist either prior to or immediately after initiating therapy. Those with heart failure, significant dysrhythmia, uncontrolled diabetes or hypertension, angina or dyspnea on very minimal amounts of exertion, and obviously patients with more recent coronary revascularization. Those are the ones I think that we really want to perhaps send to a cardio-oncology clinic. A lot of patients in Canada don't even have a family doctor, and that can be also a challenge. And perhaps, if a patient doesn't have one, you would want to consider that as well. So again, the other recommendations we had is to consider calculating a Framingham score. I know most urologists felt that was difficult, but this concept of ABCD, managing cardiovascular risk. So like STAMP, this is even easier. Assessment of risk of antiplatelet therapy, blood pressure, cholesterol, diet, and exercise, ABCDE. And of course, there are 2 C's, including tobacco or cigarette, and 2 D's, which is diabetes prevention. These, as clinicians, we just have to be aware of our patients and what they look like. How easy do they get off and on the examination table? I think these are all subtle signs that we need to pay attention to in a broader men's health context. So I'll conclude by saying that there's a significant amount of data, again, associating cardiovascular disease and LHRA risk. I think they're fairly consistent, and I think particularly we need to pay attention to those men with pre-existing disease. Whether antagonists offer any benefit over agonists, I think, is still unresolved, and I agree with Dr. Garnick on this question. But I think more importantly, perhaps, is this sort of need as broad men's health physicians that if we're going to embrace ADT and even further than that, novel androgen axis inhibition with abiraterone, enzalutamide, apalutamide, darolutamide, we need to efficiently assess cardiovascular risk. And if we're uncomfortable in managing it, let's find the right clinicians around it, being cardio-oncologists or family doctors to help us. And please remember STAMP. It's really easy to remember. STAMP. Thank you very much.
Who is attending this webinar, what is important when you approach a patient with prostate cancer to introduce ADT, any forms of ADT actually. And STAMP is a critical way how to evaluate, and then ABCD, etc. I think we have time as practicing urologists to really handle things like that, especially if we are in academic center where we have access to specialized trained nurses that can easily ask the patients about previous CVD history. And it's obvious based on your presentation, Neil, and also Mark Garnick's presentation, that if you have already existing CVD, you have to pay extra attention to that patient. So we always blame that we are running out of time with our patients. Of course, we are paying attention to the diagnosis, information, what kind of treatment, etc. But we have over the years actually not paid enough attention to CV and CVD risk associated with our treatment options. So I have a question, Neil. There was a question coming in from somewhere on this world information. If you need with severe cardiovascular toxicity associated to ADT, how to omit ADT in that patient if you want to actually take away all kind of drugs, agonist or antagonist treatment, etc., for the patient, and give something else for
right.
for the cancer.
Yeah, well, unfortunately, I mean, there's not really a paradigm for that, right? In prostate cancer, I think the best we can do is not overtreat patients, right? So I think when we look at, timing to start hormone therapy, maybe we do it a bit too early, particularly in patients with biochemical failure. And now, there's with the recent data at ESMO, it sounds like the new standard is going to be LHRH plus one of these novel androgen axis inhibitors. So I think one of the, there's, to my knowledge, not a paradigm of omitting ADT and using other drugs. I mean, we just, like the chemotherapy drugs, that's, for example, docetaxel is given in conjunction. The LHRH has always been the base or the foundational therapy by which we build on additional therapy in prostate cancer. So I'm not sure it's realistic. I think the best we can do is hold off and not inappropriately treat patients who don't need it. That I think it's not like it used to be, but I remember when I was a baby urologist 20 years ago, you'd see men with PSAs 0.6, 0.8 being treated with lifelong ADT after surgery or after radiation, which I think we've learned now is a big mistake.
It's a very good point, because I think quite many doctors, they start up ADT too early, and when there's no indication or need for that kind of treatment, they don't pay attention to, unfortunately, too much to side effects associated with hormonal therapy. So another question from one of the attendees, actually, Neil, is if you are on enzalutamide or abiraterone, do you need to continue with an agonist or antagonist treatment in that patient?
Yeah, it's a good question. Again, of all the pivotal trials using those agents have combined them with LHRH. I think the best evidence when I'm asked that question suggests that's not the case. Is we did a study, we're part of a group, including Harvard and others, where we gave neoadjuvantly. We had three groups. One was the ADT alone, the other was enzalutamide plus ADT, and the other was enzalutamide alone. And it seemed to suggest the enzalutamide alone group, the amount of residual cancers were significantly higher. So that's the only evidence that I can use to say that, that we probably still need to include the LHRH agents with the novel agents.
Well, that's what most textbooks tell you about, and that's a take-home message in many of our guidelines, to continue with agonist treatment when you add insole Avaraderone. So I think we have to do it until we know better.
Exactly.
Yeah. What else? Well, you mentioned Peter Alderson. I don't think we should pay too much attention to it. Of course, his pooled analysis has been heavily criticized, you know that. But on the other hand, he opened up his discussion with side effects and cardiovascular toxicity associated with ADT. So I think it's a relevant study for sure, but it belongs to history now.
Yeah, I think that's true.
I guess we're coming back to pronounce and the other trials. The next speaker will tell you a little bit more about it. Anything else you would like to add, Neil, before we...
No, I think that's great. I think we should hear from Daniel. He's probably the smartest of the bunch here on this topic.
Thank you very much once again, Neil. Thank you. So allow me to introduce the next speaker, who is a true cardio-oncologist and has been around for more than 20 years, president of his society. So I'm moving to St. Louis, and we have Daniel Linham with us. Are you ready, Dan, to start up your presentation?
Yes, I am. Thank you so much. And no, I'm not the smartest one on this webinar, that's for sure. And I'm greatly honored to be part of really this distinguished group. So I thank you for the opportunity. Tim, could we put the poll up first? So the question that I would like to ask the attendees is, how often would you ask for a cardio-oncology consult in patients about to begin ADT or radiation therapy for prostate cancer? And so you see the ranges of how often you may do that. So please vote. And I think we'll let them vote, and I will proceed and maybe see what the results are at the end. So can I get the poll taken off the screen there? Sorry.
You can minimize it.
Okay, very good. Thank you. So I really just want to kind of give an overall perspective. I think the previous speakers have really done an outstanding job showing the bigger studies and the rates of cardiovascular disease and all of that. So I don't, luckily I don't need to really talk about all that. So what I wanted to do is just kind of give an overview. If you look at, say, the American Cancer Society website, and I did this just a few days ago, so this is very contemporary data, and it shows that, if you have localized or regional prostate cancer, that your 5-year survival rate is nearly 100%. And, that to me is astonishing, because certainly in the cardiovascular world, there is no cardiovascular diagnosis where I would say 100% of those patients are going to live for 5 years. And that's just because, cardiovascular disease is going to have a major impact on your overall survival rate. So it's really interesting. When you look at that, you think, wow, you get a diagnosis of prostate cancer, you're almost guaranteed to be alive in 5 years. But what's misleading about this is that this seems to me that it is prostate cancer specific mortality, because let's take a look at some of the recent trials. So we've already seen other studies about this, but when you look at people with local or regional prostate cancer, there's no question that cardiovascular disease is the most common cause of death. And you see on this slide, the green arrow is just pointing to, different time points. And the dark red or maroon bar is where cardiovascular disease is the cause of death in these patients. And then when you think about metastatic prostate cancer, the same thing. It's actually probably even more prominent that cardiovascular disease is not only common, but it is the most important cause of death among patients with prostate cancer. And if we look at several of the big studies that have been quoted recently, in this webinar, then, the risk of MI or stroke or cardiovascular death in prostate cancer in general is more than 2% per year. And then if you look at people on ADT, it's estimated that it's more than 4% per year. So we recently had a paper in the JACC Cardio Oncology talking about radiation therapy on different parts of the body. And the reason why I bring that up here is because when we looked at, the recommendations for people that were going to get abdominal or pelvic radiation, there were really no screening recommendations, which especially when you look at, most patients with prostate cancer are elderly men, and they probably are going to have significant cardiovascular disease, as we just talked about. Well, how do we address their identifying their risk at the time that treatment is about to begin? So this is a really important figure from this paper, and it just highlights the point that most patients with prostate cancer, whether they're going to begin radiation therapy or whether they're going to have surgery or whether they're going to get medical therapy with ADT or something else, they're going to have a CT or CAT scan of at least their abdomen and pelvis and perhaps their chest. And what you will find is that there is extensive information about the vasculature on that scan. And so these are just examples of coronary artery calcification if you had a chest CT, and then also abdominal and pelvic, extensive peripheral vascular disease identified on the CT that was done for cancer purposes. The reason why this is so critical is that, you've seen all these slides recently, just a few slides ago about assessing cardiovascular risks. But what you're assessing on this CT is the presence of vascular disease. So that is not a risk factor, it is actual disease. And so it really emphasizes the point that you've changed their risk profile to one in which vascular disease was established. So when we think about ADT and cardiovascular risk, you've already seen slides basically highlighting all these things. So definitely there are cardiovascular adverse events. These different categories of ADT, which include the newer therapies, are known to cause significant alterations in metabolic profile, and especially Avaraderone, as was highlighted before, increases the mineralocorticoid level in your body, and that leads to significant fluid retention and hypertension. These are very real findings and very important in elderly men. So I think that, in general, there are many different aspects of cardiovascular disease that are exacerbated by these therapies. And do we actually give optimal preventive therapy in these patients? And the answer is no. But let's look at some recent trials, and that will give us some insight. So there was a very important study published last year. I believe it was in the New England Journal of Medicine for the PROSPER trial, which was a phase 3 randomized double-blind placebo-controlled study of enzalutamide in non-metastatic castrate-resistant prostate cancer. And here's the basic study design, but it was essentially ADT in one arm versus ADT plus enzalutamide. And then if you look at the overall survival curve, which here's the main presentation here, you can see that adding enzalutamide had a significant reduction in the risk of death. But look at the rate of death in this population. It's in major contrast to what we looked at the American Cancer Society website. Because if you look at the overall survival at 5 years, it's right around 50% for the whole population. The group that got enzalutamide was a little better, and that was a very important finding. But still, the rate of death after 5 years is significant. And this is actually very similar to a survival curve in somebody who was diagnosed with heart failure. So I think that there's a lot of cardiovascular disease in the background that we could treat optimally and have a better outcome. So let's look at the adverse events in this particular trial. So if you look at the adverse events of interest, especially cardiovascular in nature, you can definitely see hypertension is a very important problem. Cardiovascular events, which include MI and an exacerbation of ischemic heart disease, and then cognitive and memory impairment is really another way of describing a stroke. And so if you add up all the adverse events in the enzalutamide arm, it was 3 times as high as in the ADT only arm. So definitely enzalutamide is doing something from a cardiovascular nature that we could treat optimally and hopefully even have a bigger benefit and overall outcome. So what do we learn from the PROSPER trial? Well, certainly non-metastatic castrate-resistant prostate cancer, enzalutamide treatment resulted in a clinically meaningful and a significant 27% reduction in death. So that's an extremely important finding. It also demonstrates that enzalutamide prolongs survival compared to placebo. And then adverse events were, quote, consistent with established safety profile. Well, that's very interesting. Let's take one step further. We do know that there were many treatable adverse events that we could do a better job with. So cardiovascular disease is a critically important problem in this patient population, and it is certainly made worse by enzalutamide. And then ascertainment of cardiovascular disease, optimal treatment of risk factors, and truly cardio-oncology involvement is really essential. So I will just highlight that the Radical PC trial, which is ongoing, which is basically the intervention versus control is usual care, and then the intervention is systematic cardiovascular risk management. So this is preliminary data, and I got this courtesy of Daryl Young, who is a major investigator in this particular trial. And if we look at 26 months, the composite of MI, stroke, heart failure, venous thromboembolism, arterial revascularization was 4.8%. And the composite of MI, stroke, or heart failure or cardiovascular death was 4.1%. It's interesting that this is much higher than the pronounced data, which Dr. Flechner just showed. And what I would say is it's a major difference in the inclusion criteria, and also what he also mentioned, that cardiovascular management was optimized. So what the differences here show us is that true engagement of cardio-oncology in this patient population can reduce the adverse events to a very low acceptable level, especially given the high rate of cardiovascular events when treatment is not optimized. So we're proposing a new trial really to try to engage the whole population that's being treated for prostate cancer. So we're developing a tool, and this could be largely done by the participant and entered into data collection so that we can get organized data in a large population of patients that are being treated, and not just those with identified cardiovascular disease under a care of a cardiologist. So here's a tool, simple tool that the patients themselves could fill out, and we look to try to get this trial up and going in the very near future. So when we think about prostate cancer and adverse cardiovascular events. We do know that obviously men with prostate cancer have a high burden of cardiovascular disease. Many forms of ADT and newer therapy are known to exacerbate cardiovascular disease, and active engagement of cardio-oncology is a must to improve outcomes. And that's all I have. I don't know if we could pull back up the survey at the beginning. Okay, so this is interesting. So roughly 50% of the crowd do not get a cardio-oncology consult before initiating appropriate therapy for prostate cancer. And then if you look at people who do it most or all the time, it's a pretty low percentage at about 10%. And I think I'm sure this is reflecting practice around the world, and I think it's an extremely important point. But let's just put a question mark out there that if you were planning on doing a major pelvic surgery, a prostatectomy, how would you answer this differently in terms of whether you would get a cardiology consult pre-op or not? And I think that the adverse events with radiation therapy or ADT and other treatments are every bit as morbid as any kind of major surgery. So I'd say we probably need to rethink our approach on these issues. But anyway, I open up to any other questions, and I certainly would like to hear what the other panelists have to say about all this.
Thank you so much, Daniel Linehan. It was an elegant overview. I would like to address a few questions coming not only from myself, but also the attendees. One of the questions was actually related to the prostate trial. And that was a relevant question, actually, whether or not there was a CV monitoring questionnaire and whether they were actually monitored, the patients during the prostate trial. I guess they were, because it was striking what you said, that 50% had a mortality at 5 years. That's really alarming, I would say. So do you know whether they were carefully monitored during the trial?
Not to my knowledge. I was not an investigator in the Prosper trial, so I don't know. I don't know the details or what was required. But I would say that in the PRONOUNCE study, the one that Dr. Flechner went over, the inclusion criteria were people with established coronary disease that had a previous stent or greater than 70% stenosis. And they were all under the care of a cardiologist. And that is a distinctly different population than the rest of all of these trials. Because the rest of all these trials, the ascertainment of cardiac disease is basically minimal. And I would hazard a guess that most of the time, just like in prostate cancer, definitely in breast cancer, that very rarely do they ever check, hemoglobin A1C or a lipid panel as part of a baseline assessment in somebody who's about to undergo cancer trial treatment. And so you don't even know if they have hyperlipidemia or diabetes or whatever. You just get started on treatment and you look for adverse events. So I think that the big difference with PRONOUNCE and all these other trials is that cardiovascular disease was ascertained and was optimally managed.
Well, you are the experts, I'd say, to answer the next question coming from one of the attendees, whether or not most or any or many rather cardiologists in common settings are trained in oncology specific questions. Of course, you know how it is in the United States, but do you know how it is worldwide as well?
Well, this is like one of my favorite questions to try to answer. I think that, the International Cardio-Oncology Society is committed to, enhancing training programs and, enhancing education throughout the world. We certainly have a lot of interest in North America, but we really have tremendous interest, in many other places in the world. And so we're trying to make a difference here in this exact question. And I can say that the interest level is extremely high. So, we have no trouble getting people engaged in these conversations. And I really do feel that it's the cardio-oncology side of this equation that needs to be helpful, needs to reach out to connect with you guys. And at the point of patient care, we need to be there available. Now, that doesn't mean we have to be in the same room with you necessarily, but we need to be accessible. And, because I think that, like what was shown earlier about the Avaraderone, the change in metabolism such that you have a higher mineralocorticoid level, and that leads to hypertension and edema. But, the real issue there is we see the same thing in breast cancer.
Yeah.
You say, well, okay, why don't I use spironolactone to manage the hypokalemia and the hypertension and the fluid overload? But spironolactone, as you know, has an androgen-like, an estrogen-like effect. And so really, we would probably prefer to use something like a Avaraderone in that setting because it doesn't have an alteration in the hormonal axis. So, it's these types of decisions that I think we really can help manage these problems without interfering with the cancer treatment and actually augmenting it.
Well, if you look at the European scenario, there is an unmet need to educate our cardiologists in terms of all the new drugs in oncology, especially in the space of prostate cancer. But that's a totally different issue. You have alluded a little bit to it, Neil, so I thank you very much for that. I think there are questions from the other faculty members. Neil, there was a question from one of the attendees actually about STAMP. He would like to hear you to rephrase what STAMP stands for. That's a very simple way how to...
STAMP is S for stroke, T for TIA, A for aortic disease, aortic aneurysm. M is for, oh my God, P is for peripheral artery disease, and M is for MI, myocardial infarction. So S, stroke, TIA, aortic disease, MI, and peripheral artery disease.
Perfect. Thank you so much. Do you have
I think that's a great, acronym or whatever you want to refer to it. But I would also add, what I was showing about the baseline CT scan that is done typically in people with prostate cancer and you're looking for staging. It's astonishing how much aortic disease you will see on those CT scans. And most of the time you just kind of glide right over it because that's not what you're looking for. But I think that cardiologists should be looking for those things, and it would initiate therapy with aspirin, a statin, better blood pressure control, or whatever. So I think that it gives a stamp that this patient has already existing vascular disease that needs to be optimally managed.
I'm very interested in my co-panelists' discussion about whether or not you get a baseline ECG or EKG prior to starting ADT. And what do you do if someone's, baseline QTC or is 490 or 495?
Yeah, I'll speak now as a urologist. I must admit, we historically have not gotten baseline. I mean, we do it in the context of trials, of course, because they're mandated. I can't say we are, I consider myself fairly sophisticated in this topic, but measuring QT intervals as outside of trials is not something that I routinely do.
No, we don't do that in Europe either, I have to say, rather clinical trials, as you said, Neil. So that was a question for you, Mark, also when it comes to reducing ADT hormonal burden for a patient where the intermittent is still existing as a treatment option.
Yeah, I saw that. Obviously the intermittent studies for patients with advanced metastatic disease are potentially not inferior, but certainly not as good as continuous. for the lower forms of disease, I think it's perfectly reasonable. But regardless of whether you're using intermittent or continuous hormonal therapy, the same criteria for monitoring cardiac risk factors, weight, blood pressure, glucose aspects really need to be incorporated. And I'm not sure what the recovery rate is of cardiovascular parameters in people on IHT versus continuous therapy. I mean, that would be sort of an interesting thing to see if they actually improve after ADT during the treatment break periods.
Another question, critical question, is about antagonist versus agonist and the CV toxicity, etc. And we mentioned, I think, briefly in our trial and other trials actually looking at this. But the jury is still out. We don't have a clear-cut answer where the antagonist is by far much more safe for any patients, especially with pre-existing history of cardiovascular disease.
Yeah.
Ask about Neil and then Mark. Mark, you can start, by the way, and then Neil.
Yeah, we don't know. I mean, there's physiological criteria to suggest that that antagonists should basically be a safer agent. That notwithstanding, Dr. Crawford and I have been involved in a study looking at a very, very large disease-related group database that I'm not at liberty to say right now because we just submitted it to the AUA for the annual meeting. And it's an uncertain question. There are data on both sides. You've got the HERO trial that suggested safety, improved MACE characteristics with an orally active GnRH antagonist. You've got other data that are currently under works that may not necessarily confirm that. So to me, and you've got PRONOUNCE that sort of showed unusual data because there was no clear-cut winner between PRONOUNCE and the event rate was greater in the antagonist group, which was sort of not the hypothesis of the study. So right now, I think the jury is out. I think we're going to have to get continued. We continue to data mine some large databases, which we're doing, as well as prospectively, ask the question in a randomized fashion with the appropriate controls.
But do you think really?
It's interesting.
Yes, Neil.
I have a bit of a different take on it. I think PRONOUNCE tells us that at least if a patient is being well managed from a secondary and tertiary prevention point of view, there's no difference. I mean, I think if we look at, or at least clinically significant difference, if we need a trial of 3,000 patients to show a difference, then I would argue maybe it's not, the question's probably not that relevant anymore. I'm curious what Daniel thinks. But the other piece, for those perhaps not under the care of that type of scrutiny, perhaps there is a difference. I think PRONOUNCE taught us a lot because it was the first time that it was designed specifically for this reason. I'd like to ask the panelists and maybe Daniel, what is a non-grade 3/4 MACE? Isn't a MACE by definition major and therefore a grade 1 and 2 should not exist?
Well, I think, one person's MACE and another person's MACE are not the same thing. So it depends on the trial, what they chose to say a MACE was. So I think that you actually said pretty much what I agree with on the PRONOUNCE study, that when you optimally treat cardiovascular disease that you've established is already present, then you're going to reduce the cardiovascular adverse events to an acceptable level, which is basically what that study did. Because if you look at aspirin, statin use, and all the other types of stuff in the PRONOUNCE trial, it was very high. It was over 90%. So those people were treated optimally. And then you saw the adverse events were quite low. They're much different than HERO and PROSPER and all that, because those patients in those other trials, there was very little aspirin use, statin use, whatever, because that wasn't the focus of the trial. So I think that what you just said a minute ago, I would agree 100% with, which is that the PRONOUNCE trial really showed us, how we can reduce these events to a very tolerable level, and that maybe there's not that much difference between agonists and antagonists.
But you wouldn't consider an antagonist rather than an agonist in a patient with CV burden, in other words, cardiovascular story.
Yeah, I think that the one trial that you showed, the Dr. Martel's trial, was I thought that was a very interesting study. It's relatively small, but they were very careful, and they did 40 people in each arm, and carefully defined what happened with them. So I think that you're right. We don't have a definitive answer one way or the other if one group of treatments is worse than the other, but I do think that optimally treating their underlying vascular disease is definitely one message that we should have gotten.
So the final comment from any of you, actually, before we leave, because we are running over time here and with 45 minutes or something. So please, if you have a final take-home message, what would it be in the session?
Well, to me, it's just pay attention to men's health. So when you look at most prostate cancer patients that you will ever see, their most common cause of death in those people is heart disease. So I say this even, if a man comes to see you for a hydrocele, and he can barely get up on the examining table, and he's 48 and 30 pounds overweight and huffing and puffing and metabolic syndrome, that's a great, you're probably going to do more to help that man than doing a radical prostatectomy any day, just by trying to get him on a good path towards a healthy life.
Thank you so much. So Dan, do you have a take-home message, final comments?
Yeah, I just think that, I certainly agree with what Neil just said, but also that, cardio-oncology needs to pony up here. And I think we need to be part of this equation. And, whatever reluctance people may have had in the world about getting us involved is probably because we didn't respond very well. And I think that, we need to respond better, and we need to be helpful, and there's a lot of room for improvement.
That's the reason why we invited you as the former president of
And my comments are really to urge my urology, oncology, and primary care physicians who care for patients with prostate cancer, either directly or indirectly, to appreciate that there are modifiable risk factors for cardiac disease, and that it's a team effort to make sure that each practice that's caring for patients recognize and understand them and intervene appropriately.
Thank you so much, Marco. Thank you, the three of you, for giving us wonderful lectures and answering a lot of critical relevant questions. I would like to also say thank you very much to Therapies Pharmaceuticals for supporting these webinars, and also our staff members in Arnhem in the Netherlands, EAU staff members, for helping us out in terms of technical support, etc. So saying this, I think you've got to take your messages. We should pay more attention to our patient CV history and be careful when you give too many hormones to our patients, for sure. So thank you very much for tonight, and have a good evening and good night's sleep, all of you around the world.
Thank you. Thank you so much for the invitation.
Thank you. Likewise.
Thank you.